Good afternoon, everyone. We've got folks trickling in from the waiting room, but I wanted to say good afternoon and welcome you to our town hall. We are featuring the Mental Health Services Oversight and Accountability Commission today. Before we get started, we're going to go through a few of our housekeeping things. Those of you that have been with us through this journey kind of know what to expect, but for those of you that haven't, I wanted to give you some background on some of the features that we have included in today's presentation. First is we'll be doing a real-time polling as part of our conversation today. So we use a platform called Mentimeter. You can do that through your smartphone. You can open another tab in your browser. If you go to menti.com, and you enter the code that you see here on the screen, which is 502799, that will plug you into the polling feature for today. It's just a one-time thing. You don't have to download an app. It's not a program on your computer. You know, it doesn't track your information. So just for today, just for the town hall, we'll go ahead and our staff has put in the code as well in the chat box, so you can go ahead and get set up with that. The second part is just a little bit of housekeeping. As part of these events, we like to create a safe and inclusive environment. We like for everyone that comes into these conversations to feel free to bring whatever level of expertise or experience that they have, you know, to the table, to be able to ask questions and get answers in a way that, you know, helps them, helps their loved one on their journey. And so our house rules are displayed on the screen. For those of you that are joining us by phone and can't see what we've got here, our house rules include be kind and courteous, listen attentively and with an open mind, speak honestly, share the space, learning leaves but names stay, step up, step back, and reserve the right to change your mind. And also, as a reminder, this webinar is being recorded. We'll have those materials available for you after, and we will share for those who weren't able to make it today. So our first polling question, these couple of questions just kind of give us an idea of who's in the room. So we're asking everyone to let us know where you're joining from today. And we'll give those a couple minutes to pop up. So it looks like
Stanislaw.
Folks coming in from all over. If you want, you can also enter your response in the chat box too if you don't want to participate through the Mentimeter polling. So, we can move to the next question. We ask everyone to identify your role. Family member, consumer, are you part of one of our affiliates, provider, county representative? And again, if you don't want to participate with Mentimeter, you can also enter your answers in the chat box. So we've got some folks in the chat box, family members, folks from NAMI, San Luis Obispo. We've got some community advocates. So scattering of different perspectives and experience. All right, well, so thank you so much for entering in your answers. I don't know where I was going to go with that sentence. I would like to introduce everyone to Jessica Cruz. She's the CEO of NAMI California to provide welcome to you all today.
Thanks, Angela. And thanks everyone for being here today. We are on, I think it's our 5th town hall. And I know many of you just from participant names that I'm seeing come up and pop up, you guys have all been participating in almost all of them, and we're so grateful for your engagement, especially during this time. But we've really kind of been able to pivot the work that we've been able to do, and our partnership with the OAC, the Mental Health Services Oversight and Accountability Commission, has been key to the work that we have done within NAMI California for many, many years. And they've always been such strong partners in advocating for family members and consumers. They have a family member and a consumer spot on their commission. And the voice for NAMI is definitely heard throughout. And we are so happy to have the executive director, Toby Ewing, here with us today. He is not only has impressive accomplishments across his resume, but he too is a strong advocate for families and individuals across California in making sure that not only is our voice heard and raised, and that the leadership is brought to the table through our NAMI affiliates, but that also he is an innovative thinker in that he is taking the Oversight and Accountability Commission, the MHSA, in general as a state, to kind of new levels and new heights through his innovative thinking. He has been with the OAC for about 5 years. He's led their efforts having their first Mental Health Innovation Summit with support not only just from the OAC and the state, but federal and local mental health leaders and foundations and private sectors. He has followed up, the commission has launched an innovation incubator, which provides ongoing support. So after the initial summit, this ongoing support for counties to start talking about how do we deliver mental health services in our county in an innovative way, and how can we, and he's talked about it, I'm sure he's talked more about it now, he's inspiring and motivating to talk about how do we learn from one another and how do we regionalize the work that we're doing so that it's not when we see one county, we see one county, but we're really building off of the successes that other people have achieved in their local areas. Again, he has so many accomplishments, but he, with his leadership, the commission has built a transparency platform. If you haven't seen it, it's very cool. We at NAMI California have helped provide through our MHSA report some of that information, but it goes far beyond just the listing of the programs and services. They just developed and adopted the first of California's strategic plan for suicide prevention and initiated a project to develop statewide strategies on prevention and early intervention. And they have a separate initiative on workforce mental health, workplace mental health, and they just launched a $100 million investment in school mental health. So that is just a little bit of the work that he and his team have done at the OAC. I am so excited that he's here. I've been able to have a great relationship with the OAC and Toby. I know Angela has as well. The staff is amazing. And we are just so happy that you're here to discuss kind of some of these things, what's next for the commission, in addition to hearing and listening from our members. So welcome, Toby.
Thank you very much. Jessica, you got me excited. I was like, now I want to hear this. So I really appreciate that introduction. In talking with your team about this opportunity, I always love to share the work that we're doing. More importantly, I want to hear back from the community. What are we doing well? Where can we improve? What aren't we doing? So I'm really looking forward to giving a broad overview and then drill down into some specifics on the range of work that the commission is doing. There's a couple of poll questions that we thought we'd ask just for some guidance. The first one is really how familiar are the folks who are participating with the Mental Health Services Act? So if you don't mind, on a scale of 1 to 5, 1 being never heard of it, very unfamiliar, 5 being very familiar, give us a sense how familiar you are with the Act. Yeah, this one, I'm not able to make Mentimeter work on this one, so it's helpful to see in the slides. Let's go to the next one because this one's not working. Hopefully the next one will go. So the second one is on the work of the commission. Yeah, Angela, it looks like the Mentimeter is not working on that one either. I can't see a spot to put a number in.
I can't see it either, so.
Yeah, that's okay. We'll move on. So the whole idea here is we wanted just to get a sense of, before this conversation, how familiar are you with the Act? how familiar are you with the commission's work, and then hopefully at the end you'll give us some additional feedback around, was this helpful? Are there areas where more information would be useful? But we'll adapt. Sometimes technology makes life happen, and sometimes technology gets in the way. So here's an instance where we get a little bit of success and a little bit of challenge with technology. So again, my name's Toby Ewing. I'm the director of the Mental Health Commission. I really appreciate the opportunity. I'm going to give you a very broad overview, and Angela's team's going to help with the slides. And then I'm going to drill down into some specifics. So hold on, keep it here. I'm not quite ready for this one, but you don't have to go back. So the commission was really created for two fundamental reasons. And this is important in understanding the slide that's on the screen at the moment. First is anytime you put a tax measure on the ballot, which is what the Mental Health Services Act included, it's really important to include a body that has an oversight or accountability role, just in terms of public confidence. So the public confidence, part of the commission's role is to create that public confidence in the mental health system and the Mental Health Services Act. The other reason behind the creation of the commission is about supporting transformational change. The analysis that was done at the time that the Mental Health Services Act was written really recognized that mental health was not high on the list of priorities for the public or policymakers. When it came time to allocate new funds, mental health often was at the very bottom of the priority list. So the commission was established in addition to creating public confidence for new taxes, new revenues being spent on mental health, also to create political capital, to try to create improved understanding of the system we have today, what's working and what's not working, and to shape investment, whether it's dollars or time or attention or support, in opportunities for improvement. So how do we do that? And the commission, we have several roles. In some ways, we're like a foundation in that we allocate grant dollars. In some ways, we're a think tank and we advise the governor and the legislature. In some ways, we're a regulatory body. We write the regulations for mental health innovation and mental health prevention and early intervention. So we wear multiple hats. And this little diagram, it's not quite right. So this is an area where we'd love some guidance and feedback, but I'm trying to connect some of the multiple facets of the work that we do. At the top is data, and Jessica mentioned our transparency work, and I'll give you a preview of some of that. I'll show you some things that we have on the site today, but I'll give you a preview of a dashboard that we're about to release, hopefully in the next 2 weeks. Our data work is really about understanding what we're trying to get done, how well we're doing in terms of that work, where we're seeing improvement. The data is intended to inform the community planning process, which is an essential component that we actually have the voices of family members, consumers, and other stakeholders in that process. And it's to draw attention to opportunities or challenges that we didn't necessarily know about. And so I'll walk you through that. The data really, it can inform the work that the commission does, where we need a deeper dive analysis of what's working or what's not working. So the data can inform the commission's investment in research and policy analysis. I'll talk to you about the projects that we're doing. The idea behind that research and policy analysis is that it helps us understand what the opportunities are for improvement. And quite often we then sit back and say, hey, this should happen. But the next box is capacity building. And so we ask ourselves, when we recognize that things aren't working as well as they need to work, what tools do we have to support improvement? And so I'm going to talk to you a little bit about the capacity building that we're really working to put in place today. That's probably the most difficult challenge that we have in terms of not just the commission, but from the role of the state of California. And then that leads to implementation support for counties and community organizations and other providers, which we hope then leads to better outcomes that are expressed through the data. So go ahead and go to the next slide. Okay, so let's see if Mentimeter is working. So the first thing we wanted to ask you is just to get a sense of how familiar you are with the Commission's Transparency Suite. Is this one working? Yes, that one is working. All right. So far, we're running 50-50.
We've got some folks entering in the chat box too,
Yep.
so.
Okay, so we're 70-30, roughly. So we created the Transparency Suite in order to support communities to influence the decisions that are made in their communities. The commission had an advisory committee on fiscal, it was a fiscal oversight committee. It had all of 15 people in it. And at one point, and it had been operational for several years, and it would typically meet 3 or 4 times a year, and we would do 2 fiscal reports, beginning of the fiscal year, end of the fiscal year. And in the end, we asked members of that advisory committee, but also members of the public, what information do you want to know about Mental Health Services Act funding? What would be useful for decision making? And there was a list. And for the most part, people said, we want to know how much money counties are receiving. We want to know how much money is being spent, and we want to know how much money is in the bank. Similar things to what you might ask yourself in terms of your own financial accounts. How much money do I have? Where's my money going? How much money do I have left? And people wanted that information on the 5 components of the Mental Health Services Act. They wanted to know information on prudent reserve. They wanted to see trends, and they wanted to be able to compare this information over time and across counties. So go to the next slide. So we built a, there you go. How many have used the transparency tool? Sorry. So we built a tool, I'll keep telling the story. So we built a tool to try to capture that information in real time. We recognized that if we could get information to people in very user-friendly manner, they could actually take that information into the conversations they were having with their counties. And that we could, and this was getting closer to the public accountability that people are looking for in terms of having that sort of democratic ownership of their mental health system. And so we started off with revenue and expenditure reports, and it turned out that only about 1/3 to 1/2 of the counties had actually submitted the revenue and expenditure reports that were required under the law. And so let's go to the next slide. We'd like to get some greater usage. Okay, so funding. So the Transparency Suite overall looks at funding, programs, and outcomes. I'm going to ask you to skip ahead, and then we might have to come back to this one just because we got started here. So we built the tool that allows people to see how much money a county has in the bank, how much money is available for CSS, for PEI programs for innovation. You can click on a given county and see the information in the way it's designed in relatively real time. The revenue and expenditure reports report out for the prior fiscal year, and they're supposed to be available within 6 months of the close of the fiscal year. At the time that we created this, there were very few reports. They weren't up to date. Some counties had not submitted their financial reports for at least 7 years. Launching this tool and making this information available to the public fundamentally changed the state's approach to releasing information on finances. And the counties began to put that information together and make it accessible. Currently, however, if you go to our website today, you'll notice that the data are limited to, they stop in 2017. We don't have the 18 data, the 19 data. In part because that work revealed that counties had not been submitting financial plans. The state had not been reverting unused funds back into the state mental health fund, which would then allow those dollars to be redistributed to other counties. And so that triggered a series of changes in how the state requires counties to report. Because of those changes, the reporting format that California uses today is very different from the reporting format that the state used as recently as 2017. So it would create an apples to oranges trend if we were to try to update the data. If I imagine many of you may have seen the recent Bureau of State Audits report on the Lanterman-Petra Short Act. And the third section of that audit actually references that the state has actually prevented the counties from reporting unspent funds. We're asking the Department of Healthcare Services why they've done that. We're working with them and the counties to try to resolve some of these issues. We're hoping to be able to make the fiscal transparency tool available with updated information in the next few months. It's really going to require the state, the Department of Healthcare Services to rethink the way in which they gather data from the counties. The second thing we did is a program search tool. So next slide, please. So in addition to wanting to know about how much money counties have, people wanted to know how much money what they're spending their money on. And so we built a tool. We drew information from the county's 3-year plans and annual updates. It has about 2,500 individual MHSA funded programs in it. It's pretty good. You can do a word search. You can look by age, by ethnicity, by county. You can look for programs that are targeting specific areas like prevention or early intervention. It will pull up programs and give you a very brief overview of those programs. We're actually working to strengthen this. One of the things that this tool helped us identify is that many of the annual plans are not as accurate a representation of the service delivery system that counties have as we would like them to be. And so we're working with counties to develop a faster way to give the public easy access to information. Some people want to use this tool as a way to find services. It's really not designed that way. It's designed more of an information and an oversight tool. We built it because we want the public to understand the priorities that counties are putting in place through the decisions that they're making in terms of investing MHSA dollars. We have required counties to tell us who is served in these programs under our regulatory authority. However, that only applies to PEI programs and innovation programs. But the intent is to really be able to monitor which programs are serving which members of our communities based on race, age, ethnicity, language spoken, gender, sexual orientation, disability status, veteran status, etc. So again, the idea is to give the public real clear access to not just the dollars, but how dollars are being spent. So let's go back 2 slides. Apologies for this being out of order. So this one's on me. So the outcomes piece is the third piece. What we find people really want to understand is what are we actually getting done? And so currently on our website, you can see information on people served through full service partnerships. How many people are in a full service partnership? How much money is being spent on a full service partnership by county relative to their overall budget? The spaces, how many full service partnership slots or spaces there are by age. And one of the key issues here is what are the outcomes being achieved through full service partnership programs? And the data indicates how difficult it is to serve some people through full service partnerships, with about 10% of the people who are leaving those programs ending up in some form of an institutional setting, a jail or a hospital, and 40% seemingly walking away, and we don't know what their outcomes are, other than that they did not meet their goals. We're working to create additional outcomes, additional dashboards on criminal justice involvement. We've actually built that one. We're linking criminal justice data and full service partnership data, and then more broadly, we will link criminal justice data and broader mental health databases. There are no names, all these are de-identified data. The goal is to help the public understand, are we meeting our goals, particularly the goals in the Mental Health Services Act that say reduce criminal justice involvement. We're trying to do the same thing with educational outcomes. For that project, we really want to bring together education experts, mental health experts, and various stakeholders who are interested in those two challenges, and ask a couple of questions. What information would be useful for you to have about how well we are at supporting educational outcomes for people with mental health needs? And compared to what? Is it over time? Is it compared to people who don't have mental health needs? Is it how quickly we provide services? We really want to understand what information would be useful. And then it's what information do we actually have that we can answer some of those questions. Employment, again, we're working out what's called the data use agreement with the Employment Development Department to see if we can begin to track employment outcomes, because the Mental Health Services Act under the prevention component says reduce unemployment. So skip forward a couple to the disparities dashboard, please. One more. There you go. Okay, so this is our latest dashboard. This is a draft. We're hoping to make this available relatively quickly. What we've done is taken the demographic information for every county based on participation in a full service partnership, based on participation in the broader mental health system, based on the Medi-Cal data, and then the census data, and allows that information to be compared by race, by gender, by age, and language spoken by county. So in this display, it allows you to see if the percentage of people being served in a full service partnership is roughly equivalent with the Medi-Cal population or the overall population. And there's also, as you can see in the far right side, there's opportunities to look at trend data. And so the idea here is that this information can support understanding of how our programs are either adding to challenges associated with disparities or working to reduce disparities based on those four demographic criteria: age, race, gender, and language. We're limited to the quality of the data that we have, and so it won't answer all of your questions. And the way the tool is designed is you'll be able to click and create your own data displays and then download that information if you want, and so that you can actually do some relatively straightforward analyses that are of interest to you based on various counties or those four different demographic displays. Over time, we want to be able to do those that demographic breakdown based on issues like criminal justice involvement, employment outcomes, educational outcomes. But that's a more complicated analysis. So this is the foundation for our data work. What's happening today? Where are we? And how do we support public engagement, improved public understanding so that you can be engaged in the community planning process? All right, so data leads to our work around policy analysis. And I'm going to speed up a little bit because Angela gave me some guidance on how much time I have. There are some areas where the data indicates to us we need to improve outcomes, like the criminal justice work. And so the Commission currently has 5 projects that are active. We released a draft school mental health report a couple of weeks ago. It's available on our website. We're actively receiving feedback. The draft report has been adopted by a Commission subcommittee. It will go to the full Commission for adoption sometime in the next couple of months. We'd love your feedback. Our mental health and criminal justice report was adopted about 2 years ago. We're actively pursuing projects to reduce criminal justice involvement. In the chat, there was a question about that. It's too hard for me to do this and read all the chats and respond, but we'll have some time for your questions at the end there, which is why Angela's telling me to speed up. So we have this really exciting project on prevention and early intervention. There was some legislation a couple of years ago. It directs the Commission to establish an evaluative framework for the prevention and early intervention component of the Mental Health Services Act. And the goal of the legislation really was to, this is a couple of our projects. The one on the left is the criminal justice report. The one on the right is the suicide prevention plan. Let me finish on the PEI project. The PEI project is really exciting. What we're finding is it's very difficult for us to establish an evaluative framework for prevention and early intervention without having a clear understanding of what we're trying to accomplish. What does prevention and early intervention mean in terms of mental health services? There are lots of wonderful projects, but the prevention strategy or even awareness of what prevention means in mental health is not as mature, and it is not as consistent across decision makers or across different stakeholders as we are, say, in the public health field. or in the field of infectious disease, as we all know, based on what's happening now with COVID. Our suicide prevention report was adopted in December. There's a couple of really exciting opportunities. We were able to secure $2 million to begin implementing suicide prevention strategies this year, for this year and next year. The commission will receive a draft proposal from staff later this month during the commission meeting to begin working on suicide prevention. We're very concerned about suicide rates going up in response to all of the social isolation and the impacts of COVID. There's also some recent legislation that created a tax checkoff to raise funds for suicide prevention. We're already beginning to see some donations roll in through the tax checkoff on suicide prevention. And then the fifth report, as Jessica mentioned, is on mental health in the workplace. We see that as a real opportunity to engage employers as allies in supporting the behavioral health needs of Californians, particularly through a prevention lens. Go ahead and go to the next slide. So we do this work. We have this data. We do these deeper dives. What do we do about it? We have two primary capacity building investments. The first is the triage program is $20 million a year. The money can only go to counties. It must focus on staffing, and the focus is on responding to crises or mitigating crises. The commission later this year will put together a game plan to release those funds. We tend to release those funds in 3 to 4 year buckets. So it would be either 60 to $80 million to make sure that there's enough money to spread it around the state and that there's enough time for counties to use those dollars effectively. More recently, the legislature passed the Mental Health Student Services Act that built off of the commission's use of some of the triage funds for school mental health. And as Jessica pointed out, we recently released about I think it's actually 95 million, but it's close to $100 million for school mental health. Go to the next slide. So this slide shows, we can go to the next slide. There you go. So triage programs are blue. Go back a little bit. The map shows you the spread of those programs. And so you can see if it's blue, it's triage. If it's orange, it's Student Services Act dollars. And I don't know why we use black. That's not the friendliest color. It looks a little harsh, but that's where we have two or more programs. And we look at this because we want to make sure that the support we're providing is well distributed across the state. So, those are our two main primary programs for supporting what we call capacity building. And then the next slide. So if you remember my little suitcases, data, deep dive policy analysis, capacity building, we also work directly with counties to support implementation. And so Jessica mentioned our innovation incubator, and we also have a series of learning collaboratives. One of the refrains that we've often heard with the counties is, if you've seen one county, you've seen one county. And what we actually find is the counties actually have more in common than they have in terms of differences. Although there are unique needs, LA County and Modoc County are very different, but they'll often struggle with similar kinds of challenges. We have a series of projects. Here are 6 projects that bring together multiple counties to co-invest in creative approaches to problem solving. We're very excited about our early psychosis program that has raised about $30 million to bring coordinated specialty care as an evidence-based practice into a number of counties around the state. It's a partnership that is designed to learn from each other to strengthen implementation and data analysis. What we like about that project is we're partnering with the commercial sector to find ways to promote the use of coordinated specialty care through access to that program through commercial insurance. Our data-driven recovery project looks at criminal justice involvement and how to support diversion through a range of intercepts. Full service partnership is about strengthening full service partnership programs. That's it's roughly $1 billion annual investment. LA, Ventura, and Orange County are taking the lead on that project. We're exploring the use of psychiatric advance directives as a way to reduce the need for involuntary care and crisis response. Crisis now brings an evidence-based practice developed nationally into California that's just getting off the ground. And our performance management and fiscal sustainability project is really looking at how we can support counties that tend to get a lot of short-term grants. And how do we help them recognize that they can't survive off of short-term grants, but they can use those grants for system-level change. And if you go to the next slide, please, it'll show the distribution of those projects. And if I had a slide that put the first map and this map together, we're actually working with about 48 of the 58 counties through each of these projects. And so we're very excited about this work. It really is how we try to support. So go to the next slide. It is how we are trying to start with the data at the top, do some homework, use that information to inform a deeper dive policy analysis that we're doing. That can support and inform the capacity building, the dollars that we're making available, as well as some of the TA. But it's really about how can we enhance the success of counties in terms of implementing improved practices, which we hope will lead to better outcomes that would be reflected in the data. As I mentioned at the very beginning, and I'm just going to wrap up here in a couple more seconds, is we want to see in the data improvement in specific counties so that we can then take those strategies to scale. One of the challenges that California has had in terms of our mental health system for more than 20 years is the difficulty of taking successful projects, adapting them, tailoring them to the unique realities of different communities, but actually taking it to scale. Back in 2004, when the Little Hoover Commission did its report on mental health, and I was involved in that. I was the primary author. My kids say I quote myself, and so that's probably not fair. But part of the commission's adopted report was recognizing that family members and consumers felt the only way that you can improve access to care was to move. And that was the predominant strategy 20 years ago. What we're trying to do now is build the infrastructure that is data informed, that is guided by consumers and family members, make sure that the capacity to improve is there, and support new approaches, the adoption of evidence-based practices, and really begin to see those outcomes in the data. With that, I'd love to go to the next slide if we can. And this is a simple test to see if that helped you understand some of the work that we're doing and gave you a better sense of the kind of activities that the commission has, and can help us think about how we can actually better share information, get better guidance from you, and improve the quality of our work.
And I think we're going to have difficulties with this one too. It seems like there's something about this particular type of question that's just not working for us today.
I'm going to guess that Mentimeter doesn't actually want me to know how well you know about our work, because maybe we're not communicating to you as well as we need to. But that's, so thank you very much for the chance to say hello and to share some of the work with you. I'd love to respond to questions. I've seen a lot of questions in the chat. Angela, any guidance or support about how we can make this work with 75 people online?
Yes, so I think we might have one more polling question right after this, I think about the components of the commission's work. So we'll switch to that question. And then I'm gonna scroll through. There were a few questions that came up during the presentation, so I'll pull those out. And then, you know, we've got a slide and we can skip over it here in a second. But for those of you that have questions, because of the number of folks in the room, it's easier to manage it through the chat box. So if you have a question, or if there was, you know, a part of the presentation you want clarification on, you know, pop a note into the chat box and we'll get to as many of those as we can. If for some reason we run up against, you know, a time crunch, we can gather the remaining questions and I can work with Toby and his team to get you answers to those, much like we had to do with the Department of State Hospitals event. So let's see, let's go to the next slide, because I think we're having some trouble with the polling feature.
And there's my email, and somebody had asked if you could have my contact information. Absolutely. I will just warn you that I easily get a couple hundred emails a day. And so I try my best to respond. I respond to every email I get, unless you're selling me something or offering me some investments in a foreign country. It just may take me some time.
Awesome. Thanks for the heads up on that. So again, if you have any questions, I'll start working through the chat box. While I say that, I just quickly, I didn't get a chance to do this at the beginning. I wanted to say thank you to our NAMI California team. We have some staff that work on the back end that are managing this platform, that are advancing the slides. They've been inputting the links into the chat box. So for those of you that want more information or to actually, go to the Transparency Suite and play around with those tools, those links are in the chat box. We'll also include them in the follow-up materials. There's some other information about the project, the different projects that Toby talked about, as well as the innovation and the other grant programs. So we'll pull all that out, include it in our follow-up email. But I just wanted to say thank you to our team. Brianna and Ragini work really hard behind the scenes to make this event super successful, and there is no way I could do any of this without them. So I just wanted to make sure that that was out there into the universe. So I'm gonna start at the top, and it looks like there's a question that came in earlier, and it was clarification around some of the work, if it's, and I might ask this person to Joe, if you could clarify your question here about the criminal justice contacts, that way I can make sure that I ask it appropriately. We'll get you some clarification on that. There was some notes here about quality of data, the numbers being a little bit older. I don't know if you want to touch on that quickly about why some of the data is from like 2016, 2017.
Yeah, so we don't have any of our own data. All our data comes from the Department of Healthcare Services, or it's linked with other departments. Some of the analysis that you're seeing has never been done before. And so it's taking us a while to get access to more recent data. And so for that, but because of that, we tend to look at trends. The fiscal data is stalled because the state, under the terms of AB 114, which was a trailer bill from a couple of years ago, AB 114 required the Department of Healthcare Services to go back and recalculate unspent funds that counties were required to revert back to the state. And so DHCS underwent a process of revisiting all of the fiscal reporting going back to 2004. And that's where they implemented a new methodology. And so we're still trying to sort out some of the differences in the data with them. We get calls every 2 weeks asking us for updated information on unspent funds, on county balances. And those calls come from the governor's office, from lawmakers, from the media, from county supervisors. So we're pushing really hard, but we are dependent on other state agencies. Sometimes the data is just not as up to date as we would like it to be. But we're really striving to make sure that you have access to the most reliable and timely data that is possible. And that includes redoing some of these data systems. So if you go back to that LPS audit, one of the recommendations in there is that the state really needs to rethink its strategy so that the commission and the auditor did recommend that the legislature authorize the commission to build out a much broader data strategy that focuses on funding, programming, and outcomes, not just MHSA dollars, but all mental health dollars, all mental health programming, and outcomes above and beyond the PEI outcomes that are included in the MHSA. We anticipate there'll be legislation on that next year. Great question. I wish I could give you more up-to-date data.
So the next one is if there is data about civil commitment LPS conservatorships.
So we don't have that data. That's one of the issues that the auditor raised, is the need to improve that information. And the auditor raised that in the context of their analysis looking at 2 counties showed that only 9% of people coming out of conservatorships, whether they were short-term LPS holds or longer-term conservatorships, only 9% were actually connected to community-based services with a warm handoff. And so the auditor is actually recommending building out the data system in part to better understand what's happening in terms of our ability to serve people with high-end needs. So we don't have any information independent, we actually have not even looked at that issue yet. What we have done is we've asked UCLA and some other academic partners to scour the literature in the world to identify key metrics that would be useful for monitoring outcomes. And so we're trying to do a couple of things. We're trying to build the data capacity, meaning the data use agreements, the technology systems, the secure servers, and all of that, in order to do this data analysis, and at the same time asking what information would be useful for decision makers. Because clearly there's a demand, but we don't even have agreement on what we should be looking at, what we should be measuring and monitoring.
Thanks. Next question is, does the commission support assisted outpatient treatment?
So the commission has, to my knowledge, has never actually engaged on that issue. You know, so I don't know. I mean, we have some very clear rules of procedure that you know, the commission, in order to have a position, it needs to deliberate and talk it through, and sometimes that means doing these deeper dive policy analyses. But we have not actually had a conversation with commissioners about AOT. You know, I think, as Jessica said, the commission by statute has 2 family members on it. It has 2 peers on it. It has providers. It has education leaders, including the state superintendent and a local superintendent. It has law enforcement leaders, the attorney general and a local sheriff. It has health system representatives. So, you know, I think, I honestly, you know, to my knowledge, I've been here 5.5 years. They have never actually engaged on that question. I think it would be a challenging issue for the commission if it was sort of put forward in that sort of, you know, yes or no format, because of the long history of tension over that issue. But the real answer is they've not actually taken a position on that.
Thanks. Next question is, how often does the commission meet?
Typically, okay, so this is a great question. Typically, what the law says is the commission may meet 4 times a year or as needed. Traditionally, the commission meets monthly. It usually takes one of the summer months off and then December off because of the holidays. With COVID, we've been meeting on an as-needed basis. And so because we review and approve county innovation plans, and those dollars, counties can lose those dollars if they're not dedicated to an approved plan. We've been meeting more frequently, so I think we met 3 times in June. Hopefully with some changes in the law and some better planning in terms of the timing of innovation requests and proposals, we won't have to meet that frequently, but generally once a month, with the exception of June and December.
So next question is, can the commission recommend programs to counties, or is it only the counties defining programs for their respective county?
So sure. So what the law requires is that counties go through a community planning process, community engagement, getting the voices of consumers and family members and other stakeholders, that county proposals go before their local mental health board for review. It doesn't have to be approved, but it has to be agendized and discussed. And then if counties proceed with a plan that does not align with the vote of the local mental health board, sometimes they're called commissions, local commissions, then the county has to explain why they didn't follow the advice of their local board, and then it goes to the board of supervisors. So from a governance perspective, the counties make independent decisions. The exception is county innovation plans. But part of our work, part of our capacity building dollars is we can incentivize counties. So recently, before the passage of the Mental Health Services Act, and that was one of the questions, those funds come from MHSA revenues that are allocated to the state. 5% of MHSA dollars are available to the state. Prior to the passage of that law, the commission said, we will provide grants to counties if they're willing to partner with schools around meeting the mental health needs of students. And so there's a number of ways that we can guide county decisions, support them, or create incentives, but we have no authority to direct them.
All right. Next question is, what is the funding source of the Mental Health Student Services Act funding?
Yeah, so that was the question I just answered. Of the 5% that was available last year, what the legislature did is they recognized that there was about $10 million in annual revenue that was available for local assistance. And so they provided the commission $10 million ongoing funds for the Mental Health Student Services Act. But they also had about $40 million of one-time funding. So it was $50 million in our budget last year and $10 million ongoing until, assuming there's enough revenues. And so it is MHSA funds that otherwise would be used for state operations. I will say that prior to that, the agreement that the legislature had with the governor on that funding strategy, the Senate had also attempted to invest $500 million of general fund money. So the Senate version of the budget was going to be $500 million general fund, $50 million MHSA, of which $10 million of the MHSA would be ongoing. There is some but prior to COVID and the economic hit, the legislature was very interested in putting additional general fund money into school mental health. We'll see how that looks moving forward as the economy, we hope, recovers.
Next question. Are the counties legally forced to report their data?
Well, yes. Basically, yes. The counties enter into a performance contract with the Department of Healthcare Services that includes a requirement for data reporting. So, for example, the law is very clear. So we'll take, and data is broadly defined. There's lots of specific data, but it's more complicated than that. So the law says today, and it has said for many years, that counties must provide a revenue and expenditure report to the state within 6 months of the close of the fiscal year. Fiscal year closes June 30th, and so by the end of December, counties have to submit a plan. But for many years, the rule with the law was not enforced. Recent changes now say that if a county does not submit their financial report, then the state can withhold up to 25% of their monthly MHSA distribution. And the state has begun to do that, and that has resulted in much higher reporting rates for these financial reports. There are other data areas, however, where those incentives are not in place, where the quality of the data are late, they're incomplete, they're inaccurate, and so data is a huge challenge in California. And that issue is not limited to mental health. That's true in almost all aspects of data collection between the state and the counties.
So the other question, I think this relates back to the clarification I asked for Joe. One of our affiliates does a lot of work with in criminal justice, and so he had some questions about measuring, some of the data there. So, for example, they have a peer-to-peer training that they do in probation, and it says that those who have taken the class have shown to reduce their contacts with police. Is this what you are measuring? So maybe just elaborating a little bit on some of the criminal justice data.
Yeah, well, so so we're not quite to that level yet. The last year, 2 years ago, the commission received $5 million in our budget to support, this was the launch of our innovation incubator. So we got $5 million for our innovation incubator. On the condition that work focused on reducing the number of folks who end up in a state hospital with a felony charge under an incompetent to stand trial designation. The state has seen a long backlog, a tremendous backlog of people who need services because of a felony charge, and the courts have determined that the individual is incompetent to stand trial. Normally, under those scenarios, people would then be directed to the state hospital for services until competency was restored, and then the judicial process could move forward. The state invested about $100 million through the Department of State Hospitals. State hospitals did an interesting analysis. They looked at the people coming in, and they found that despite having a felony charge, and typically about a dozen misdemeanor charges prior to that felony, that 46% of the people being referred to state hospital for services had not received community-based care within the 6 months prior to the felony charge. So the reality was lots of individuals who have high needs, high mental health needs, as evidenced by the IST designation, very well known to the counties, as evidenced by the dozen or so misdemeanor charges, but not getting care. So we are partnering with a number of counties in what we call a data-driven recovery project to do a similar kind of analysis, starting with how can we better understand pathways between community mental health and jails? Who is coming into the jail having received services? Who's coming into the jail not having received services? At its simplest, we might say, can we figure out if we could track people with mental health needs who are in the jail and the percentage of those who had community mental health services, it can help us understand why those community mental health services aren't resulting in, aren't leading to a better outcome than jail involvement. We're serving them, they're still becoming involved in the jail, right? That suggests that our programming is not as effective as we need it to be. For those people who are not getting community services and they have mental health needs, that suggests we have an access problem. These are people in the community, they have needs, but the first time we're finding them is through jail-based programming. And so this data-driven recovery project is designed to support counties. There are 2 cohorts, 5 counties each. The first cohort has been doing this about a year. Yolo County is the lead county. And we're working with a consultant who sits down with them and says, okay, what do you want to know? What data do you have? How can we begin to unpack this? And the intent is that will support counties' use of innovation funds to design alternate programs. And that conversation, again, has to go through that community planning process. And so the idea here really is that we can help counties do some basic homework, use that homework to support the design, the rethinking of their community programs in consultation with their community partners to reduce justice involvement. So in a given county, Joe, absolutely, it could include information around who participated in what kind of training. In another county, it might be somewhat different. We can give you a list of the counties that are participating. I can share that with Angela. This is called our Data-Driven Recovery Project. The second cohort of 5 counties, that grouping is just getting off the ground. So I don't know that we've even identified those 5 counties yet. But we had a cap of 5 counties in the original cohort. More counties wanted to participate, and so we're trying to launch a second group to learn that way.
Thanks. Yeah, I'll grab that with you, and we can share that in the materials as well. So the next comment is around there's a current ceiling spending 5% for community program planning funds, but not a floor because meaningful engagement is dependent on education and training of the community. Could the OAC mandate funds to be spent on community education on MHSA, advocacy, infrastructure of the California mental health system?
We have no authority to mandate that. That would be a conversation with the legislature. That would be a statutory rule. Our regulatory authority is limited to PEI and innovation. So any change in that process, I think, I will share with you, however, that our approach sometimes asks this question of whether or not this is a policy problem or whether or not the challenge you're focusing actually is a capacity and an implementation problem. Sometimes the perception is that counties aren't interested, and therefore mandating is the way to force them to do something. Sometimes we recognize that counties are interested, but they don't necessarily have the capacity or the tools, or it's more difficult or more expensive than they feel like they can afford. So sometimes in those scenarios, rather than a policy solution, we begin to think about a training or a technical assistance solution or even an innovation solution. Unfortunately, those strategies tend to work best with interested partners and less well with partners who are not interested. And you can imagine what that would mean in your own life, right? And so therefore people often do go back to a statutory strategy. So we really try to think about what's behind the problem so that the solution can be tailored to the actual reality. And quite often those problems are very different in different counties. Some people are just not interested. Some people don't, they don't have the, it's not their price. They would do it if they had more time and money. Some people want to do it today, but they don't know how. And we really try to respond to each of those problems or approaches differently.
Okay, so next question, and there's a couple of acronyms in here that admittedly I don't know, but it's, does the MHSOAC or the Commission get data involving the most high acuity persons, involving LPS conservatorships and state hospital stays, including NGI, MDO, SVP, and IST?
No, we don't. Yeah, we don't. We might be able to. Some of those data sets are more confidential, so to speak, because they're involving the criminal justice system or diagnoses. But no, so what's really interesting is the law says that the Commission can have access to data from departments that receive MHSA funds. Sometimes some of the data that we're interested in, like employment data, EDD doesn't receive MHSA funds. And so sometimes we actually have to change the law. But typically what we do is we first start with, what questions are we trying to answer, right? What would be useful to know and why? We really try to, there are too many questions out there to try to go after all of them. So we step back and say, what information would be useful for decision making and for which decision makers? And then we say, okay, what data are currently available? And can we use those data in order to answer those questions? And if the answer is yes, then we say, do we have legal access to them? And what would it take? And we have had to go to the legislature to change the law in order to get access to some data. That's hard enough. The most difficult one is where the data don't exist. And we have to start from scratch to build data reporting systems. It becomes very expensive. And so through this process of what's important to know, are there proxies? We really then try to create a set of priorities that are achievable given the resources that we have. And our resources are very limited. And they've been focused on, as you saw, some pretty high level information. How much money do counties have? What are the programs that are out there? And how many people are we serving? You're getting down to much more detailed data that's really important. And that's why we're starting to work with counties, because counties have more granular data, more detailed data than the state has. And this is as much about helping them use their data to reduce, bad outcomes, to improve good outcomes, as it is trying to create uniform. That's more important than spending hundreds of millions of dollars to create brand new data systems. Unfortunately, no, we do not have the specific data with all those acronyms that Angela will learn what they stand for in the next day or two.
I will.
Not guilty by reason of insanity, incompetent stand trial, and there's a couple other things.
No, I like adding more acronyms to the list of things. As most of us know, we only talk in acronyms. So I'm always excited to see what I don't know. So, all right. So next question is, what is the Commission's position on SB 665?
All right. So the Commission is opposed to the Umberg bill, which would allow MHSA to be used in jail environments. The bill has recently been amended, dramatically amended. The Commission, at this time, the Commission is not going to revisit its position. My latest conversation with the chair is that we will not revisit our position.
Okay. So there's a few other questions around like the community planning process. I think you've touched on that a little bit and kind of where the Commission is with that. There's one here. How do we get transparency in the project selection process by our MHSA County Director?
Well, that's a conversation that you need to have at home with your local mental health board. And so this is a wonderful example. For several years, for 5 or 6 years, I was a governance consultant to the Senate on local government issues, right? And so handled all the legislation on Bagley-Keene, actually not Bagley-Keene, but the Brown Act and open government rules and transparency. And, we can write the most well-intended law possible, but what's really important is the details, is how this works. And as I said earlier, sometimes the law is actually quite good, but practices, the implementation is where people have challenges. And I think in this instance, there's a nice balance between important public process and the ability of local governments to operate efficiently. That doesn't mean it works in every community. Some communities feel like the community planning process is quite transparent. We recently undertook a project to strengthen the youth voice regarding mental health investments. We have a youth advisory committee that is hosting a series of youth-driven idea labs. There's a couple we did one in person in UCSB with 5 counties. We have 2 online that are coming up. And some counties have asked us, how did we create such robust youth engagement? Other counties have said, hey, we've got great youth engagement. So, I think what we would want to look at in this issue around strengthening the community planning process or creating transparency is to really look at what's out there today. And, there may be some areas where transparency is not something people are interested in. That's sometimes what we find, but most of the time people aren't opposed to transparency. They just really haven't. It feels very risky. It feels threatening to public officials. And we haven't necessarily talked through how it can work to strengthen the role that public officials play. And so I would suggest, first, it would be a wonderful project to look at the different ways that counties structure their community engagement process, the way they structure who's on a local mental health board, who appoints those boards, what role do they play, how do they operate, what information is available. We fully anticipate, we actually want our transparency work to shape work that's being done at the community level. This isn't information that is designed to support my 16 commissioners, my 16 bosses, passing judgment on what's happening in your counties. The idea here is to model, and so I would suggest have some conversations with your behavioral health directors, with your local boards, see if they could make that an opportunity to use innovation funds to strengthen those processes. We would love to engage multiple counties in talking about how to strengthen the community planning process and create that transparency. I want to go back to one of the things I said at the very beginning. The commission was created to support trust and to create political capital. It's very hard to create political capital for mental health if trust is low.
Absolutely. And I will say too, that like I said, there were a few questions that kind of came in through this. And one of the, we're looking at one of the future town halls, including Teresa Comstock, who's the executive director for the California Association of Local Mental Health Boards and Commissions, so that we can talk about this. So that for those of you that, have these questions, I think there's a broader conversation that can be had with the folks at Cal BHBC. I know that a few of you that are joining us today are also part of Cal Voice's Access Ambassador program, and they've done a lot of work in their current OAC contract around the community planning process. And so I think there's definitely opportunity to continue the conversation, provide more education and information on requirements and kind of who's doing what. I do think that there's some counties that have done a wonderful job in their community planning process, but it's really just sort of looking at the landscape more generally. So that's definitely something I see us continuing and including, throughout a few more of these town halls.
Yeah, I would just add, and Jessica mentioned the partnership that we have with NAMI. We are investing, I think every 3 years, something like $15 million in strengthening stakeholder voices. I've not done a state-by-state analysis, but I'm going to posit that that's the largest public investment specific to giving voice to consumers and family members and key stakeholders in decisions about our public mental health program. That doesn't mean it's working as effectively as we need it to work, as evidenced by the question. But I do think that California has the infrastructure way beyond what other states have. And so, it could be very useful to look at whether or not that infrastructure is being deployed in ways that are meeting your needs. Again, because it's about trust. And it's that trust that is so necessary to allow people to sit down and talk through things that are working, understand them better so that we can take those to scale, recognize the things that aren't working, right? And it also means, and this is where innovation is really important, if we want counties to be creative, to take risks, which is what innovation requires, they need to know that their community, the public, will have their back when an innovation project goes awry, because they're not all going to work out, right? The only sign of things not being, that innovation, that we're not as aggressive enough, is that every innovation project is perfect, right? And that means some of these will flop. And counties need the support of their partners, even if you don't agree on everything, if you're going to support their ability to improve over time.
Yeah, and I think too, the questions we've had around these town halls was really just to sort of bring folks like you and some of the other, entities and agencies that sort of have a custodial hand in the mental health system to really help folks better understand who is in charge of what, who has the authority to mandate this over that, and, where those decisions are being made. So hopefully, and, the feedback we've gotten is that, these conversations have really helped sort of connect the dots around, how to create change locally and at the state level. And so, even with regard to the community planning process, so many of us are having these conversations. I know our affiliates, we have a lot of really active affiliates working closely with local decision makers. And so I think just, broadening that conversation and bringing in more folks, better understanding, the commission's role versus Department of Healthcare Services or whoever, this is really, exactly what we had envisioned for these events. So the next question, we have a few more, and I know we're kind of getting close to the end of our time, but we have a few more questions. The next one is, are counties audited? And if so, how often?
Yeah, well, so audit is an interesting word. They can be in a classic fiscal audit. So recently, the Bureau of State Audits they audited Shasta, LA, and San Francisco, specifically looking at their implementation of the LPS laws. The Department of Healthcare Services does. I think your question is more aligned with what are known as triennial reviews. So the Department of Healthcare Services has a performance contract with the counties, and they do, once every 3 years, they do a deep dive review of every county. So it's a compliance review. Counties also are required to have an EQRO, which I've forgotten what the acronym stands for, but it is a periodic quality assessment by a third-party reviewer. So counties actually are audited in multiple ways by multiple bodies with different areas of focus. Sometimes it's a Medi-Cal audit. Sometimes it's, as in this case, the LPS audit. And then there is the broader triennial review and the broader EQRO review. We don't have an audit function. We don't have auditors. We have no audit authority. We aren't the mental health police, to use that phrase. We don't focus on compliance. The Department of Healthcare Services does focus on compliance. We are more focused on promoting transformational change.
Where can I access the formula used to calculate the distribution of MHSA funds to the counties?
Yeah, that's a great question. So the law says that the Department of Healthcare Services develops that formula in consultation with the County Behavioral Health Directors Association. So I'm sure it's in a file cabinet someplace in the Department of Healthcare Services, but you should ask the Department of Healthcare Services. I actually don't know. It's a weighted formula. The law allows it to be adjusted annually, but I don't actually know how frequently it is reviewed. But Healthcare Services has that.
All right. Let's see. The next question.
Nobody's ever asked that before, so it's a good one.
How confident are you in the passing of the Peer Support Certification SB 803 bill, and why especially is this the fourth attempt in doing so? On a scale of 1 to 10, how much weight is the OAC behind this?
So, oh my gosh, that's a trick question, so to speak. Is it going to pass, and do you really want it to pass? So yes, the commission is a sponsor. We have been a sponsor. We're actually not technically a sponsor this year. We've been a sponsor in prior years. Senator Bell is the author. Senator Bell is on the commission. We have helped, we provided TA in writing the legislation. This year, the committees only allow him to have 3 sponsors. And so this year they asked us to step back as a sponsor and to be a supporter to allow others to sign on as sponsors. How confident am I that it's going to be passed? On a scale of 0 to 10, 0. This governor did not sign it last year, citing fiscal issues. This year we have a $54 billion deficit, so I would be shocked. What's interesting and sometimes gets missed is this governor and others, there's tremendous support for peer certification. That's not the issue that has been challenging. The issue is who pays the non-federal cost. And the state has been asking the counties to pay the non-federal cost, and the counties have been asking the state to cover the non-federal costs. And so the issue has less to do with whether or not there is support for peers and creating a certification strategy for peers. It has more to do with the requirement for there to be a specific Medi-Cal billing code to pay for peer services. We've talked with some of the stakeholders in the author's office about separating those 2 issues, the peer certification issue and the funding of peers, in order to allow the peer certification piece to move forward while the state works on the financial issue. There's been less interest in that. Tomorrow, the commission has a meeting of its Client and Family Leadership Committee, and we're going to focus on this. One of the things that we've been doing while the bill has been moving forward is engaging different organizations to talk about how we can support the peer movement, saying peer certification in the legislation is an essential component of a strategy, but it is not the only strategy the state of California and the commission specifically should be pursuing in supporting a peer certification role. And so tomorrow's conversation, we're going to report out a little bit of some of the conversations we've had in the communities around the state, and engage our Client Family Leadership Committee to really talk about how we can fully support peer certification. So I would say, how much are we committed to peer certification? 100%. How confident are we that this governor is going to sign it? Last year he said it was too expensive and he didn't have a $54 billion deficit. You can do the math better than I can.
All right. So let's see.
How's that for a happy note? Sorry.
I mean, we can keep on the policy train here. A couple of the other comments that have come in about, where was it? The new ones popped up, so I lost it. There it is. This is also with regard to SB 665, which it's in here as the jail-based community mental health innovation plan. How the funds might be shifted depending on where this goes, and then do you know if youth under 18 are included in this plan?
So the original bill, okay, so some history here, and then the recent amendments. So the original bill, so the question was, can MHSA be used in a jail environment? And the Mental Health Services Act is silent on that issue. The Department of Mental Health put in place a regulation saying that Mental Health Services Act dollars cannot be used in a jail environment. The MHSA itself was very clear that the dollars cannot be used to support services in prisons or with parolees. So people served by the people for whom the state is primarily responsible. Senator Umberg introduced 665, and it would have opened the door to using these funds to support jails. The concern has been that would allow significant levels of funding to be used, to be taken out of community-based programs and put into jail-based programs. Some people also expressed concern that MHSA is designed to only be used for voluntary care, and make the argument that any service in a locked environment is by definition not voluntary. More recently, but the bill moved out of the Senate, and the bill landed in the Assembly Health Committee. And so the Assembly Health Committee has said, well, in order to address the issue of limiting the amount of money that could be shifted out of community-based programs, are there ways to cap that? very early in these discussions, there were negotiations about allowing innovation funds to, limiting the dollars that could be used to innovation funds, and that would, in effect, put a 5% cap on the amount of money that could be accessed. We, sort of informally in these conversations with CBHC and others, we said, if you want to put a cap, just put a cap on it. The problem with allowing innovation funds to be used in the jail is that innovation funds are of limited term and is designed to learn and then use other funds to support whatever the lessons are there if the innovation was successful. So the bill, so I don't know who these negotiations were between, but what the bill says now is that on a very limited pilot project, no more than 8 counties, innovation funds can be used if and only if the commission gives permission. So under the terms and conditions that the commission would authorize, and that the commission should then advise the governor and the legislature if the regulation limiting MHSA use in the jail should be re-examined. Is this something that should be done? And across all these conversations, I think there are 2 ways of thinking about this. There's a camp that says, absolutely not, hell no, bad, we should just not even go there, because it would, quote, be a run on Mental Health Services Act dollars. And 2, it's encouraging use of these dollars in locked facilities. The other way that some people think about this is it actually opens up jail-based care to the community planning process. And so the authors, the committee would require this, any county that wanted to use innovation funds still has to go through the community planning process. And so the other camp here is that it actually could strengthen the connection between community-based care and jail-based care and actually enhance the voice of consumers and family members around what happens in jails. So this is going to be really, if this passes, it's going to be really challenging for the commission because a number of counties are very interested in this. And I will add that although the county behavioral health directors are opposed to the legislation, the county supervisors, I think CSAC is actually in support. So this is another really tough tension that we're seeing in California.
And then one last question to piggyback on that. Is the commission working with any of the folks that are actively writing opposition letters or,
We have written an opposition letter. It's on file. You should be able to see it online.
Okay. Let's see. I'm going to pull one more question and then let's see, this is moving. There was one and I really liked it. Where was it? I'm trying to scroll through so I can make sure I grab this. The commission's plan to sort of bridge the digital divide, with everything that's going on, what are the plans long-term for the commission to stay online? We've had a lot of conversations around how this space has, created a lot of access opportunities for folks who might not necessarily be able to travel to a commission meeting, and not even just the commission, but really any sort of decision-making body, these opportunities to engage through Zoom and go to webinar and to provide public comment, through email or phone. Has the commission had any conversations about what that might look long-term, even once some of the, gathering restrictions are lifted?
So we are of the mind that we'll be operating in a remote environment for the rest of the calendar year. We don't know if it'll go beyond that, right? We're, like everybody else, we're taking advice and guidance from our public health leaders. So, we're getting better at doing community engagement. I was in a meeting yesterday, a couple of days ago, with 300 people. That just doesn't happen in person, right? It doesn't mean, it's really interesting. We have more people in our meetings than we've ever had before, but we have fewer public comments. And so that suggests that it's easier for people to get in, but it doesn't necessarily mean that people are really engaging. And then, as referenced by the issue of the digital divide, it's very difficult for people who do not have internet access to the technology for them to participate. Prior to COVID, it's also very difficult to get on a plane, a train, or a bus and come to Sacramento for one of our in-person meetings. But we do maybe hundreds of community meetings a year. I mean, all told, maybe I should say many dozens, because it's maybe in the 70 or 80 or 110 range, where we were in the community. And we can't do that now. And it's in those meetings, when we go to other people, that's how we can actually create improved access. And so through much of our work, traditionally, we would engage with several hundred or 1,000 people, like on the school mental health report, right? Before we released the Mental Health Student Services Act, we did 4 community forums, Sacramento, Richmond, Fresno, and LA. And they were in the evenings, and we brought refreshments. And so we have no better answers than anybody else on bridging the digital divide in this current environment and how to handle that. We are working with the Department of Healthcare Services to support a FEMA application to begin to build out a digital strategy to support mental health needs for more Californians, something the state has not done before. We're piloting it now with some commission funds, and there's a $1 million proposal and a FEMA application, so we'll see what that looks like. And part of the thinking is, can we capture the best value of these digital Zoom kinds of meetings, online, virtual, and digital strategies that have become essential during COVID, and sustain them in a post-COVID environment so we have the best of the in-person and the digital and virtual strategies. That does nothing for our most vulnerable residents, homeless people, people who don't have the tech or hotspots, but we're really trying to get there.
Awesome, thank you. So we're right up against the end of our time. And so I know that there were some questions that you all have put in. There was a really great question about Medi-Cal and folks transitioning over to Medi-Cal for services. So I'm gonna pull all these questions together and we will get the answers to those that we couldn't get to today, and we'll provide that to you all in a follow-up posting. I did want to just say, again, thank you to my team for all of your support behind the scenes. We do have some materials. We'll send out the presentation from today, as well as the recording. We'll make those available on our website. You can also access any of our previous town halls on our website, and it's here up on the screen, namica.org /town hall. So we'll have those available, and then any of our upcoming. So next week on the 20th, we have CSAC, which is the California State Association of Counties. September 3rd, we have Department of Managed Healthcare. September 14th, we've got CPEN, which is the California Pan-Ethnic Health Network. And then we've got the California Alliance for Children and Family Services. And then we're working with some other partners for our October dates. So we've got the link here in the chat box. And then we also have a link for our post-event evaluation. If you could just take a few seconds, let us know what you thought of today. If you have any ideas or thoughts about information that would be helpful to you as we think about who to invite to present at our upcoming events, I'm always glad to have that information. I'd rather bring you stuff you need than what you don't. So again, just thank you to everyone for your participation today, the comments, the questions. We'll definitely be in touch with some follow-up. My contact information is here on the screen. If you have any final thoughts, or if you think of anything, over the next couple of days, you can always reach out to me and we'll get you that information. So with that, I just want to thank you for being here today. I hope everyone is safe and well. And for those of you that had kids going back to school online this week, a little extra hug and a bit of patience for all of you as you navigate that world as well. So I just wanted to say thank you. Jessica, did you want to add anything before we sign off? Okay. All right.
I just appreciate Toby and his thoroughness and answering all the questions. I know that it's a lot, and it's so good that we're able to at least bring this. This could be like a series of webinars with all the information and all the work that you guys are doing. So thank you so much. Thank you everybody for being so engaged and participating. And thank you, Angela, and your team for all of the work that you've done in putting this together. So have a good rest of your afternoon.
All right. Thanks everyone. Have a great day.
Everybody.
Bye.